Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of tonsils, including those I no longer have. Dr. Travis Brown, you know how to stir up the trauma because I was a young adult when I lost my tonsils or had them removed. And the pain, thankfully I've forgotten. I just have a vague recollection of what it was like. But when I was there, I was told, no, none of this jelly and ice cream business. Toast with Vegemite. Keep that scraped clean.
Do you think the surgeon liked you?
I'm beginning to wonder now.
Well, look, Vegemite toast sounds like a bit of a punishment. You might have been a little bit of a difficult patient. Were you a difficult patient, Steve?
I was a glorious patient.
So, yes, we're talking about tonsils, and it wasn't until I started looking into the histories of tonsils that I found out how controversial this procedure or this surgery is, and it still is today. If you're looking at throughout history, you can actually see ebbs and flow of when people thought it was a great surgery to have, and lots of people got it, and there was times when it was considered barbaric and to be avoided at all costs. And the range of surgical opinions, as we're going to get through to some of these quotes, that you can see, hundreds of years, thousands of years ago, they had very different opinions, opinions that some last today. And it's interesting because the surgery in itself is actually it's an accessible area, but it's not an area that you can actually sort of stop bleeding well. It's sort of just, And
the thing that gets me at the moment is we often on This Medical Life talk about the swings and roundabouts, the trends in medicine. It's very rare that I'm plotted on the graph of where we were with a certain bit of thinking. I'm really worried about what I'm going to learn today.
Well, to be honest, I was thinking that I was going to ask you a question, have you had tonsils? But clearly you have. But I would have thought you would have had it as a child as opposed to having it as an adult.
Got my appendix out as a child, so I can't wait till we do appendectomies.
And so I would have put money that you would have had it out as a child, just because the age that you would have been, we were probably in a time when we were having more tonsillectomies than not. And so, but the first ever report of a tonsillectomy is actually from a Hindu medical text, 1000 BCE.
When the phlegm and blood are deranged in the soft palate and tonsils, they become large and like a full bladder, accompanied with thirst, cough, and difficulty of breathing. When troublesome, they are to be seized between the blades of a forceps, drawn forward, and with a semicircular knife, the third of the swelled part is removed. If all be removed, so much blood may be discharged as will destroy the individual. If too little is removed, it will produce an increase in the swelling with fainting, swimming of head.
And so that's several thousands of years ago and this is a medical text, so it's clearly been done long before this. But you'll see through the ages, you get the ancient Greeks and Romans. You had Galen who wrote about this, and he used a snare for what we would call a partial tonsillectomy.
They ought to be disengaged all round by the finger and removed. If they are not separated by this method, it is necessary to take them up with a blunt hook and separate them with a scalpel, then to wash them with vinegar and anoint the wound with a styptic application. Those who extirpate the entire tonsil remove at the same time structures which are perfectly healthy, and in this way give rise to serious hemorrhage.
And so 600 years later, we have Paulus of Argetia, who's still ancient Greece, and he describes his complete tonsillectomy.
When, therefore, they are inflamed, we must not meddle with them. But when the inflammation is considerably abated, we may operate, more especially upon such as are white, contracted, and have a narrow base. But those which are spongy, red, and have a broad base are apt to bleed. Therefore, seating the person in the light of the sun and directing him to open his mouth while one assistant holds his hand and another presses down the tongue with a wooden spatula, we take a hook and perforate the tonsil with it and drag it outwards as much as we can without drawing its membranes along with it, and then we cut it out by the root with a scalpel suited to that hand, for there are two such instruments having opposite curvatures. After ligation, the patient must gargle with cold water or oxycrate, or if hemorrhage occurs, he may use a tepid decoction of brambles, roses, or myrtle leaves.
And so you're starting to see all the different ages about how they're managing this, whether they cut out all of it and they used a curved blade. Now we go into the Middle Ages, and this is when it actually fell out of favour. They believed it to be a bad operation, and they had to use, if they did need surgery, they used ligatures. And what this was tying it off and constricting it. You'd cut off the circulation, but the problem with this was it would cause intense pain and was prone to severe infection. And a writer at the time stated this:
"This procedure is liable to resolve itself into physical combat between the surgeon and his patient."
We come into the 1600s, and it's important to remember, again, these are people who are having operations without any anaesthetic. They talk about bleeding, or there will be lots of bleeding in an area that's inflamed at the back of the throat. So these patients would have also been coughing and spluttering, all kinds of challenges. By the 1600s, the procedure is known. You've got snares, you've got ligatures, you've got excision, and they've got tools developed for this specific operation. And there are continuing differing opinions. And we got a Dr. Hester from the 17th century writing about it.
"This operation is not only too severe and cruel, but also too difficult in the performance to come into the practice of the moderns because of the obscure situation of the tonsils."
And so in the 19th century, you can see different authors having just these competing views.
It is easy to cut off the whole or any portion that may be necessary of the enlarged tonsil. The operation can be fulfilled in a moment of time. The pain is very little, and the hemorrhage so moderate that it has not required any alteration in 4 cases in which the doctor has recently performed it.
And so then we've got a physician, Goodhart, who was renowned at the time, and he wrote,
"It is comparatively seldom that an operation is necessary, and fortunately so, for patients manifest great repugnance to it. Children grow out of it, and at 14 or 15 years of age the condition ceases to be a disease of any importance."
And so in 1903 there was a Scotland study that examined 1,200 children from 2 different schools. Now they estimated about 5% of children would benefit from tonsillectomies. But by the 1930s, the rate of tonsillectomies for children under the age of 14 was 33%. And so some doctors considered this rate too high, such as Dr. L.W. Dean.
To me, it is certain that the tonsils in infancy and early childhood are part of the defence mechanism of the body. They protect the organism against those factors which cause them to become acutely swollen.
There was also a study in England when 400 children migrated from Spain, and you could see even different countries treating their children differently with regards to this.
Another revealing feature of the group was the appearance of the children's throats. Less than 2% had had tonsillectomies performed, and in a very great number of cases the tonsils were as large or larger than walnuts. But the incidence of both cervical adentitis and otorrhea was only approximately 0.4%, and that of obvious respiratory infection almost incredibly low. The same is true of nasal discharges and respiratory obstruction. The important question arises as to what will happen to these children now they've reached England. Owing to the difficulty of obtaining parents' consent to operation, it is devoutly to be hoped they will retain their tonsils. since it might well prove disastrous if these were to be removed before the children had had opportunity of acquiring general immunity to catarrhal infections. It's also perhaps of interest that of the 200 adults examined, none showed appreciably enlarged or unhealthy tonsils.
When we look at this as a historical trend of recent history, in 1967, 120 of 10,000 children had tonsillectomies. In 1985, that number was 51. In 1990, that was 81. In 1998, that was 65. And so there is this unusual trend. You're not really comparing like with like. Historically, there's many reasons why tonsils would have come out. This would have changed over time for us, but this is the rates of tonsillectomy as it came in vogue for different cultures and different countries. And so today we were wanting to get an expert with us and really find out who needs tonsillectomies, what do we understand about it from our current condition in both paediatric and in adults.
I want to find the surgeon who did me in the 80s, if he's still with us, to get him to listen to this. But also, I don't think I've found a time in history that I would have been happy, because 1600s they started going against the cutting and they just tied it off.
You might have wanted to live in the Middle Ages then.
Yes. Dr. Eric Levi is a triple fellowship-trained specialist otolaryngologist, or ear, nose and throat surgeon, head and neck surgeon, based in Melbourne, Australia. He has completed fellowships in head and neck surgery, facial plastic and reconstructive surgery, and paediatric otolaryngology in Canada, Australia and New Zealand. Dr. Levi has subspeciality interests in adult head and neck cancer, sinus diseases, conditions of the salivary glands, pediatric complex airway reconstruction, pediatric head and neck tumours, vascular malformation, sleep surgery, reconstructive rhinoplasty, and otoplasty. Eric is an honorary fellow at Murdoch Children's Research Institute, a clinical senior lecturer at the University of Melbourne, and a supervisor of surgical training at RCH. He's currently undertaking a Master in Health Administration in his spare time. Dr. Levi is our guest on This Medical Life podcast. Levi, welcome.
Thank you so much. It's so good to be here. So good to finally be chatting with you.
Thank you, Eric. Now, I am talking to you as a man with no tonsils, and I lost them when I was an adult. So I'm very keen to hear how this conversation flows. But let's get the basics out the way first. What role do tonsils actually play in our health and our illness?
That's always a challenging, big question to start with. In essence, a very important role, but also not an irreplaceable one. So one of the beauties about our immune system is the intricate complexity, beauty. There's even redundancy in the system. So when we talk about tonsils, we talk about those lymphoid tissues at the back of our throat. And I'm sure you've heard it before. It's the first line of defense, or it's a filtration device and all those things. Well, yes and no. When we study the reasons why tonsils exist, it's more not a filter, not the first line of defense, because I would say your skin, your saliva, your teeth is your first line of defense. The tonsils is part of the complete intricate beauty of the immune system. It is a lymphoid tissue that is gathered around the back of the nose and the throat. And what it does more than anything, it's like a surveillance center. Things fall into it, and then your T cells, B cells, antigen presenting cells learn to identify these foreign antigens, and it activates the rest of the immune system to actually work to identify this as friend or foe, as something to fight or something to allow into the body. Now, it's not a perfect filtration device because we eat a lot of stuff and only very little bits get into the tonsils. We breathe a lot of stuff, very little bits get into the adenoid or tonsil. So it is a surveillance center. But like any other parts of the body, sometimes things can go wrong as well. So yes, someone like yourself who have lost your tonsils, there must be a real reason behind that. And look at you, you're doing really well without your tonsils. So in a sense, although it is an important part, it is also not a supremely, irreplaceable part of the body. When a body part gets diseased, sometimes treatment is required, which might include surgery. So yes, it is part of the lymphoid tissue, part of the immune system. Does it fight infection? Not really. What it does is it captures and provides a surveillance. When you take out those tonsils, there's still hundreds more left behind, believe it or not. People think that those two tonsils are the only thing in the throat.
Can I ask about the adenoids? Do you consider adenoids separate, or, I mean, we often talk about them together, but do you think it's separate or together?
Similar but different. So yes, they are also lymphoid tissue. They are also surveillance centers, if I could put it that way. Now, at the back of our nose and throat, there's this ring called the Waldeyer's ring. I might be pronouncing it wrongly. So it is nasopharyngeal tonsils at the back of the nose, which are also called adenoids, and then tubal tonsils around the eustachian tube, and then the palatine tonsils at the back of the throat that you know of, and then there's also lingual tonsils behind the tongue. So that's kind of a complete circle from the nose, the back of the side of the nose, the side of the throat, and the back of the tongue. That's all tonsillar tissue. Adenotonsils, tubal tonsils of Gerlach, palatine tonsils, lingual tonsils. So they are similar in histology or cellular structure, but they are different. There are certain differences as well histologically. Yeah.
So in this first segment, I want to focus on children. I know this is going to be a huge question, but what are the common causes children get large tonsils?
Yeah, very common questions. Up to about 48,000 tonsils get done in Australia every year. Up to 500,000 tonsils get done in the US every year, based on my last reading. Why do children get tonsils? So tonsils and adenoids, it's interesting. When we study the adenoids, the tonsils and adenoids tend to increase in size in the first 3 to 5 years of life. And that's interesting because the most common age for tonsillectomy is around about the age of 4, 5, and 6. The adenoid tends to then slowly involute over the age of about 8 to 10. Studies show that tonsils continue to enlarge up to puberty, and then they start to decrease. Either way, people ask why. Well, in the first 2 to 3 years of life, you are exposed to so many new things, new viruses, new bacteria, the environment. So sometimes it's just the nature of a child being exposed to the things in the environment that causes the tonsils and the adenoid as the first location for viruses and food materials and all of these foreign bodies to enter the breathing or gut pathway. So those exposure to new antigens are probably the main reason why tonsils can get enlarged. Of course, there are infective causes, bacterial tonsillitis, that might cause the tonsil to really blow up and they sometimes don't really decrease in size. And the other thing as well is things such as allergies. A lot of studies about tonsils have been done in the 1980s and 90s. In 2024, the prevalence of allergic symptoms, we have so many children allergic to, nuts, pollen, grass, dust mites, and all of that. Again, where do they go to? The first place it lands is the nose, the nasopharynx, the throat, the tonsils. So no surprise that some of these things can actually be the cause. So essentially, number one, normal physiological growth, sometimes made worse by a lot of exposure to viruses and bacteria, such as in childcare centers when there's 20 over kids in one room. Then allergies is probably another thing, and infection as well. Of course, not in children, but in adults, sometimes they can be enlarged due to a malignant process, such as lymphoma or squamous cell carcinoma, but that's a different topic altogether.
What conditions do we assess children to have a tonsillectomy then?
Yeah, probably the two most common indication or reason for a child to get tonsillectomy is obstructive sleep apnea or recurrent tonsillitis. Those are the two major reasons. There are a few other reasons that is a bit uncommon, such as if you had a child who have had a transplant and they had a large tonsil, then we worry about post-transplant lymphoproliferative disorder. If a child has an asymmetrical tonsil, we would worry about a lymphoma, for example. But probably the two most common is obstructive sleep apnea and recurrent tonsillitis.
So how can someone tell, I guess either doctor or patient, that their child may have obstructive sleep apnea?
It's challenging because, as you know, obstructive sleep apnea happens during sleep. So not many of us observe a child's sleep. So I often think of it as two major factors. What are the daytime symptoms and what are the nighttime symptoms? Now, if we can look at the nighttime symptoms, that would be great. But that means that you actually have to study the child sleeping at night. Now, we do that obviously in a sleep lab where you can objectively identify what happens during sleep. So the nighttime symptoms are snoring plus pauses in the breathing. So apnea is when there is cessation of airflow. It's defined as at least 2 missed breath cycle and a reduction of oximetry, oxygen saturation. Of course, you can't do oxygen saturation at home, but you can do that in the lab. But you can actually count the number of seconds or the number of times that a child actually stops breathing. And if you have 2 breath cycles and you stop breathing, and then you stirs and wake, that's considered 1 apnea spell. And if you have more than 4 apnea spells, that's already considered an apneic, a mild sleep apnea. So that's something that can happen at night. Restless sleep, sweating at night, snoring plus pauses in the breathing, waking up in the middle of the night, gasping for air, dry mouth. All those things are nighttime symptoms. The daytime symptoms, and so parents need to look into that, or GPs maybe need to encourage parents to look at how their child sleeps and records that at night. The daytime symptoms is a symptom of a child who has very little sleep. They are grumpy, they are restless, they might be very moody, they might be labile in terms of emotion. But then again, these are also symptoms that mimics a child with behavioral disorder, for example, ADHD, autism. So there is a lot of overlap. And I have to say as well that sometimes the daytime symptoms are also affected by the fact that there's so much intrusion of media and screens in our life today that the quality of sleep of a child is poorer because of that. So when a child has poor sleep, sometimes I want to differentiate whether or not it is true obstructive events, breathing problem, or the child just has a poor sleep behavior, onset, too much screen intrusion. Oh, that's another different topic altogether.
Talking about the other side of things, so tonsillectomy for infection, when do you consider that is the path to go down?
Yeah, so every child is obviously in a spectrum, so severity is really what it comes down to. How severe are these symptoms? Frequency is important. Severity is also important. I mean, of course, for example, you can think about a child. If a child has an immune disorder or allergic disorder and has a significant infection, and every time they have an infection, they end up in the hospital, then less frequency might be needed to be classified for tonsillectomy. So I don't know whether you're going to ask me about the Paradise criteria.
Oh, you're ahead of me there. There you go.
Right.
Let's go into that.
So Paradise criteria. So Paradise is a doctor in the US who actually published a paper with his team back in the 1980s. So we're talking about a 40-year-old criteria, where it basically defines a tonsillectomy for recurrent tonsillitis in a child as being more than 7 episodes per year, or 5 episodes every year over 2 years, or 3 episodes every year over 3 years. So that's how I remember it in my mind, 7, 5, and 3. But interestingly, they actually define the criteria as fever more than 38.3, enlarged lymph nodes in the neck, pustule, kind of purulent tonsils, and also a positive swab for strep. So in a sense, we don't do swabs on every child who has a tonsillitis. So we kind of assume that they have a tonsillitis, but it could just be a simple sore throat rather than a true, strep throat. Basically the criteria is defined as that. Fever over 38, large lymph nodes, purulent tonsils, and a positive swab, throat swab. And that's kind of how it is defined as the Paradise criteria.
Is there an easy rule of thumb for GPs listening to be able to distinguish between moderately affected children and severely affected children?
Yeah, that's again the challenging part. Working with, I'm sure you do too, but working with families and children, sometimes the child's personality and the parental, kind of anxiety or expectation can really alter the severity of the disease. If a child has a moderate low temperature, but is so miserable that they can't go to school and miss a school for a whole week, is that more severe than a child with swinging fevers up to the 40s and sweating and having rigors, but is still happy to walk to school? Sometimes it's quite challenging. So the honest truth is it is very hard to truly identify severity. But all I can say, I think, is to say, based on the objective criteria, if you have 7 or more documented sore throat and tonsillitis episodes that is affecting the quality of life of the child, then you might meet the criteria for that. Bearing in mind as well, if the child has other coexisting disease, if the asthma and the diabetes gets worse, if the child has trisomy 21 or immune disorder for any other reason, then maybe not waiting till 7 episodes a year might be needed. Again, it's all the discussion about the risk and benefit of the intervention, because you can keep giving, antibiotics, or you could consider a surgical intervention also with its own risks and benefits as well. So it's a discussion. Yeah.
Eric, you've mentioned the risk word a few times. What are the risks of surgery for children?
For a tonsillectomy plus minus adenoidectomy, so that's one single code, and we often pair that together with adenoidectomy. Rarely, if the adenoid is not enlarged, we leave them alone. But yeah, what are the risks? So obviously, we're operating in the mouth of a child. We remove those big tonsils. And at the end of the procedure, believe it or not, we leave that area bare open. So you have an open wound at the back of the throat with muscles that is open. If you think about it, if I operate on your hand or leg, I'll stitch the skin close together and I'll put a bandage wrap around it. At the back of the throat, you can't really do that. So studies have shown that sutures or any dressing, by the first swallow or by the first cough, all the sutures will go, And so that's the reason why pain is the most significant part of the journey, and it's often worse around about day 3 to 6. Worse when it's done as an adult because of other reasons, like the reason for a tonsillectomy. But pain is a common. Everyone just goes through pain. Secondly, the risk of bleeding, because it's an open wound at the back of the throat. You're still eating, drinking, moving, swallowing. Saliva is bathing that area. Imagine if you have a wound on your hand and you keep spitting on it. Of course, it's going to be uncomfortable. Of course, it's painful, and there's a risk of bleeding from a secondary bleed point of view. So there is that risk. Quoted risk is around about 3 to 4% internationally in the first 14 days. However, I need to put a really strong caveat to that. That's the risk for bleeding and infection in a tonsillectomy, where a diathermy or a cold steel is used to basically remove the tonsils, leaving bare muscle. Nowadays, the standard of care has actually changed, and in a lot of places around the world, we now do tonsillectomy. So not a complete removal, but we basically ablate until there's a thin layer of tonsil just still covering the back of the throat, but the wound is no longer open. So the quoted risk of bleeding and pain has decreased. For example, this is the standard of care in the UK, tonsillectomy through a method called radiofrequency ablation. And so that has reduced the readmission rate, the pain rate, and all those things. So it's worth discussing with your patients that now we can alter the risk profile. In Australia in general, we still do a cold steel, diathermy, or monopolar, bipolar. But now there's so many new techniques on the field now. So you have to discuss that with your surgeon as to which method is employed.
I need to ask this from my post-traumatic stress aspect of having gone through this as a 25-year-old.
Yeah.
And it is about how quickly children can eat and drink after surgery. Yes. But also, when I was laying in that hospital bed I remembered watching the Brady Bunch as a child, and they got fed jelly and ice cream, and I thought, I'm looking forward to this.
Yeah.
But I was in the mid-'80s, and they said, no, that's changed. Yes. We're giving you toast
Correct.
with Vegemite to keep scraping that clean.
Yeah, look, I don't know that I would be giving someone toast and Vegemite to be scraping that clean, but the truth of the matter is that, yes, there is studies now that shows that in essence, if you return to normal diet as soon as possible, you are likely to have less pain and less risk of bleeding. So rather than the old style of just jelly, ice cream, custard, we actually recommend patients to return to normal diet as soon as possible. Now, if you think about it, as long as you chew your food well, it'll be soft by the time you swallow it. And the act of chewing actually releases saliva, which is healing and helpful. And it is also, immune mediation. And it also reduces the stiffness. When you're sipping on soup, you're not really chewing, you're not really moving the muscles there. Yeah.
When was the ideal time for a patient or a child, let's say a child for this point, to be referred to an ENT surgeon?
Always very challenging because I know, nationally and globally, getting into an ENT surgeon can be quite hard. It can take quite a few months. There's not too many of us around the place, unfortunately. And if you live in a country, you might be hundreds of kilometers away from the nearest ENT surgeon. I mean, what I would say is we can go back to that Paradise criteria. If you see a child with those two major issues, number one, either obstructive sleep apnea, and the parents are aware that, the child having pauses in the breathing, pauses in their sleep, and notices that, then that's probably a red flag to say, take a video of your child sleeping, observe the child's behavior during the day, record some of that, and then come to see an ENT surgeon. If they're just snoring, 12% of children snore, about 5% have sleep apnea. We want to catch that 5%. And with recurrent tonsillitis, using that Paradise criteria, is probably a good first thing to think about. That 7, 5, 3, 7 in 1 year, 5 every year for 2 years, or 3 every year in 3 years. That might be a good one to start with.
That's why I love doing this podcast. I'm going to tell my wife I'm part of the 12% when she complains about snoring. Just before we take a very small break to come back to look at older people, is there any final advice, Eric, for doctors or patients regarding children and tonsils?
Yeah, it will always be controversial. You see, this has been done for hundreds of years. You have quoted, there's a lot of history behind it. And because this is such a common problem, there's so many people with multiple different strong opinions. So you will always find people who say you should never remove the tonsils because it is there for a reason. Well, the same way as the appendix is there for a reason. If it is diseased, it is something that needs to be considered. And it's also something where I have to say it's a quality of life discussion. There will never be a simple test that tells you that you need to have your tonsils out. There will never be a perfect test to study the need for a tonsillectomy. It's all about discussion about how the tonsils are affecting the quality of life for that particular child, whether it's true because of sleep apnea or recurrent tonsillitis.
All right, let's take a very brief pause. I'm going to go in the corner and just cry for a little while, and then we'll come back and we'll look at this from the perspective of adults.
Wonderful.
We're continuing our conversation now with Dr. Eric Levi. Eric, we're going to turn attention to adults. What are the common reasons adults may be considered for tonsillectomy here in Australia?
Very similar reason as children. First of all, probably the two most common reason is going to be recurrent tonsillitis and obstructive sleep apnea. But then as an adult, there are also other potential reasons that might become more obvious than in children. Malignancy is one. So we have a rising incidence of HPV, human papilloma positive virus, HPV positive, oropharyngeal cancer. That's basically oropharyngeal squamous cell carcinoma. Oropharyngeal is basically referring to tonsils, palatine tonsils or lingual tonsils. So there is a rising incidence of that, and we know that. So malignancy, something like a lymphoma is always a possibility as well. And the other things are things like bad breath, halitosis, tonsil stones. Those are common other reasons for a potential tonsillectomy. But that's worth discussing. And again, it's less clear-cut than in children.
Do the Paradise criteria also apply to adults?
Technically not. So the Paradise criteria was really designed because they're based on a study that only recruited 1 to 18 years of age. So technically, it's not applicable. But in general, it is also a good kind of rule of thumb recommendation. One thing that I noticed in my practice is that when adults get tonsillitis, often they are a lot more severe than in children. So the sore throat in adults, if it is truly tonsillitis, tend to be a little bit more severe. I've seen patients who have almost nearly had, an ICU admission or even a renal transplant because they've got, complete systemic sepsis. There are other associated syndromes such as, Lemierre syndrome, which is basically kind of an infection like a thrombosis of the internal jugular vein around that space as well. You have things like, kissing disease, the infectious mononucleosis, which is glandular fever. This happens in teenagers and, mostly towards adulthood. EBV, tonsillitis, because that's tonsillitis from Epstein-Barr virus. So, yes, it is, we can use the Paradise criteria as a general guideline, but technically it wasn't designed for adults. That this is where discussion with the patient is important. If you're a public speaker, if you're a podcast host and a radio announcer and you have recurrent tonsillitis, you might not need to wait for 7 every year. You might need to have it done slightly earlier. It's all about the risk and the balance. So the only absolute indication for removal of the tonsil is obviously a small cancer in the tonsil that can be cured with a complete excision around the tonsil. And even then, we actually do a pharyngectomy, remove a bit of the muscles as well. So that's a different discussion when it comes to cancer. But everything else is relative discussion with the risk and benefit with the patient.
If I recall, I think I was begging my doctor to do this and he was holding off for a while. Does
Yes.
that rings true for you?
Absolutely.
Yeah.
And to be honest with you, as a surgeon, a pediatric tonsillectomy, it's much easier to perform than an adult tonsillectomy for reasons that in an adult, usually the reason is infection or abscess. If you've had an abscess behind the tonsils, paratonsillar abscess, otherwise known as quinsy, dissecting through that is a lot more challenging. And studies have shown in adults tend to suffer with a little bit more postoperative pain, or maybe I should say a lot more postoperative pain. I don't want people to think that it's a walk in the park. It is not at all a walk in the park.
Actually, on that, how long is recovery for adults after surgery? Because it's a long time ago and I'm sure my brain has blanked it out.
Yeah.
But I have a feeling it was at least 4 weeks for me of feeling pretty horrible.
Yeah. We usually generally say that the highest risk of bleeding is in the first 10 days. So pain was around about day 3 to 7 or day 3 to 8. Highest risk of bleeding is around about day 5 to 10, but up to day 14. So we kind of usually tell patients 14 days of recovery, 14 days of feeling miserable. But the highest risk of bleeding is around about day 5 to 10.
Now, you've mentioned tonsillectomy. Is that, if I got the pronunciation right?
Correct.
Do you think that's going to become the standard of practice in Australia?
It can be. It probably will be, just because we are slowly moving in that direction. The biggest issue in this kind of situation is always the risk. If you think about it, if you perform a tonsillectomy, you're removing 95, 97, 99% of the tonsil tissue, but there's still some left behind. So there's always a concern, and the long-term studies are probably not quite out there yet, to say, will these patients continue to suffer from recurrent tonsillitis in the future if you're leaving behind a little bit of tonsil tissues? I've just recently looked at those studies in children, and the rate of reoperation, meaning tonsillar regrowth requiring a repeat operation, is 1%. So you got 2 to 3% risk of bleeding with an open tonsillectomy or a complete tonsillectomy, or you have a 1% risk of reoperation with a tonsillotomy. Again, which way do you go? So you kind of end up with having a discussion with a patient to say, look, you've got recurrent tonsillitis. These tonsils have been horrible for you. You've had an abscess. If we don't remove everything, you might have a recurrence of it. But if you remove everything, you might risk a little bit more higher risk of pain and bleeding. Again, it's all just about balance. How a country surgeon might choose that as well might matter. If my patient was 3 hours away from help and unable to take 2 weeks off to be in a capital city, then I might choose a tonsillotomy, and I might discuss that with that patient to say, look, if you have a tonsillotomy, you might be able to go back to work about a week earlier, and studies have shown that there is some improvement in return to school, return to work, or return to activity with a tonsillotomy. And if you live in a country, if you reduce the risk of bleeding, that is actually a significant thing. So often I have this discussion with the patient.
Now, I'm going to mention, because you mentioned it before, you've got sleep apnea, you've got halitosis, and group strep A. How common are those reasons for having a tonsillectomy?
Yeah. For sleep apnea in adults, so the difference between children and adults, obviously, oftentimes in children, because they're still growing, their palatal structures, nose structures, tongue structures are still growing. And so we only want to remove the part that really obstructs, which is often the tonsils and the adenoid. In an adult, when we talk about sleep surgery, which is a whole different topic altogether, we look at a person who has had a fixed bone and soft tissue structures. So we look at their septum, turbinate, sinuses. We look at the palate position, and usually, physiologically, their adenoid and the tonsils have shrunk. So oftentimes the tonsils and adenoid are not always the main reason. However, if the problem or the obstruction is at a throat level, the oropharyngeal level, then we might do tonsillectomy plus UPPP. Tonsillectomy, uvulopalato-pharyngoplasty, plus tongue ablation, tongue reduction. There's quite a multi-level. The way I tell patients is there's 7 billion of us on this planet, so there's 7 billion permutation of how the airway can be obstructed. So in one person, it could be the tonsil, but in the other person, it could be the hard palate, the crowded teeth, the small jaw, the deviated septum. So in a sense, that tonsillectomy becomes part of the discussion in managing the snoring or sleep apnea if it was the part of the reason. Not every person who snore needs a tonsillectomy. They might need a nose operation. They might need a rhinoplasty. You don't know. Or they might just need to, do other things like a splint and CPAP and other means. So surgery is only one of the many options of therapy.
Now, we've mentioned it a few times, and I don't want to get into the depth in it because this is completely another podcast in itself, but what are the flags for, or at least something for a GP to consider that someone may have mouth cancer or something just to flag that this isn't quite right? Is there anything that you can tell us about that?
Yeah. So two things. Patients will present to a GP with, I've got sore throat, doc. I've got pain in my throat. Swallowing is difficult. And of course, we all need to have a look down. And if the story fits with tonsillitis, almost certainly what you're going to see is somebody who can open their mouth with kind of symmetrical, enlarged, infected tonsils with purulent discharge. If you can't open your mouth, you got trismus, and one side of the tonsils is pushed medially, that could be a peritonsillar abscess. That might just need to be drained. However, when it comes to malignancy, then what we need to be thinking about are asymmetrical tonsils or lesions on the tonsils itself. So if you're seeing an ulcerative change, a lesion on the tonsil that is asymmetrical one side to the other, that is a risk for a potential malignancy. And so those are probably my red flags. Of course, anytime anyone has neck nodes that are asymmetrical, need to look inside the mouth because of that HPV positive malignancy. Now, again, the story of HPV positive oropharyngeal cancer is an amazing story in itself because, nasopharyngeal cancer, potentially EBV mediated in a specific ethnic group. HPV, oropharyngeal cancer. So why does EPV go to the adenoid and HPV go to the tonsils and the lingual tonsils? These are just amazing things that is actually changing the way we think about tonsillar histology as well. Papillomas or warts can happen in the junctional region between the mucosa and the tonsil, whereas HPV positive malignancy actually sits in the tonsil tissue itself. So it's quite interesting in that sense. But anyway, to circle back to your question, what are the red flags? Asymmetrical tonsils or lesion on the tonsil, any neck nodes is a red flag that needs to be looked at, potentially biopsied. Yeah.
Wow, what an absolute journey this has been. In closing, Eric, what are some final advice, some comments you might have for doctors, general practitioners in relation to the tonsils? And my goodness, you have shone a light on them.
Yeah. I want to say that things have changed. A lot of us, for example, a good example is that Paradise criteria. There was basically, I read that paper recently because of, this interview. So I had to make sure that I knew what I was talking about, or at least I sound like I knew what I was talking about. So I looked at the paper and it's interesting. They recruited between 1971 to 1982 or something like that. So they took 11 years to recruit. And the paper was published in 1984, so 40 years ago. So things have changed. Although we use those things as a helpful guide, the method of tonsillectomy has changed. The risks associated with tonsillectomy has been altered by some of this method. Not everyone needs a tonsillectomy, of course, because we went through a phase where every big tonsil was removed on the kitchen table. It used to be that every intern had to do a tonsillectomy before they graduated. Things have changed. We are a lot more selective. We are managing the risk a little bit better. But at the same time as well, I think there will never be a time when there will be a simple test that tells you have to have your tonsils out. It's all about how the health of your tonsils or the illness of your tonsils affect the quality of your life, both in children and adult. And particularly in adult, I would probably be saying that it's more than just, the bad breath, the halitosis, the snoring. You have to think about the bigger issues such as sleep apnea, and the tonsil is only one part of the big thing. And for adults, because of that rise in HPV positive oropharyngeal cancer, just being aware, and they are not the typical head and neck cancer patients who are, smokers and drinkers per se. That's again an old stereotyping of a head and neck cancer patient. Mm-hmm. Today's patient could be anyone. I still remember my first HPV positive cancer patient was a 30-something-year-old, lady who was a very, kind of a professional. No traditional risk factors. So being aware that if you've got lymph nodes in your neck, it doesn't matter if you're a smoker or not, have a look at your tonsils as well to make sure that there's no lesions around the tonsils. And that's probably the red flag here. Okay. We want to catch them early, as you know.
I'll just slip in one bonus question before we leave. When you do get a sore throat, that's a bit more than just the normal one. My go-tos are some Strepsils maybe, or a little bit of whiskey.
Yes.
Do you have any go-to symptomatic relief?
I'm only a simple surgeon, so I don't have the top shelf stuff. Look, what I find interesting is that I think different people have have got their own different go-to. So there's a lot of traditional, non-traditional, cultural, social beliefs around what is best around the throat. But what's interesting is things have been studied, like things like, a good honey and lemon. The good things that used to be passed down from generation to generation actually has some scientific evidence to it now. So good old lemon and honey. Some people say pineapple actually might be sucking on some pineapple might actually be good. Anything that soothes the throat would be good. If it is viral, it's probably going to be self-limiting for a few days and you manage that well. If it is viral plus bacterial, then you might be a little bit more unwell, but most of the time you will do just fine. Of course, after about 5 to 7 days of persistent illness and you're not quite right, you probably do need to see your local general practitioner for more advice.
That's my advice. At the bottom of the whiskey bottle, I call the doctor. Dr. Eric Levi, thank you so much for being part of This Medical Life.
My pleasure. It's been awesome. Thank you so much for your time.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.